Good morning. I am Lauren Loba, and I am the Director of Safety for Anesthesia Services at Texas Children's. And this is my partner, G. Mathen, from the pharmacy at Texas Children's. We have nothing to disclose. Arnie? Shouldn't the thing have popped up?
There you go. We literally just saw it.
I know.
Oh, you opened the wrong one.
Oh.
That happens.
Small technical difficulty. So the first breakout question for this morning we're going to warm up with is, describe the relationship between anesthesia and pharmacy at your hospital. I think I have to get the class. So that's much more positive than I thought it was going to be. But there's some words that resonate, I think, across many relationships that can be siloed or strained, fair. But G and I are talking about our story today and our partnership. So in 2021, G and I were on the ISMP Peri-Op Guidelines roundtable, and it was virtual because it was 2021. And I remember being in this roundtable, and we're all talking about our individual practices and what we do. And there was this discussion about technology and Epic, and G offered up some comment at Texas Children's, and I sat there and I was like, I don't know where he works because I work there and that does not happen. And so that was 2021, and we moved on, and I didn't know G and G didn't know me at the time. I was a relatively new attending at Texas Children's. And then we fast forward about a year ago, and we had an RCA from an event with a medication error. And it was around ketamine. There was a ketamine shortage at the time. And so our normal process wasn't going to work. So we had to go through pharmacy for a ketamine preparation. And there was an error because people were doing unfamiliar work patterns to work around the solution. And one of the things that came up in the RCA over and over, which is consistent across all RCAs probably, is communication. Communication was the biggest breakdown. And G and his pharmacy team offered up their recommendations in the RCA, and I had mine. And it was work as imagined and work as done. So on the pharmacy side, G and his team think something happens in the OR because that's what the books say or that's what the guidelines say. And then I offer up this nice, lively comment of, that never happens. I don't know where you are. And so what we realized was that we had an opportunity to form a relationship. As Dr. Eckhorn said yesterday, you have a problem, you form a committee. So we formed a committee that is called the Perioperative Medication Stewardship Committee at TCH. And like was highlighted by some of our other colleagues in the room, you got to have the stakeholders. So G and I are the co-chairs of that committee, but along that committee, there's nursing leadership, PACU leadership, there's a couple surgeons because we need their input from time to time, but it's predominantly anesthesiologists across our 4 campuses, and the pharmacy leadership across those 4 campuses. Because at Texas Children's, we have an even bigger challenge of, we have now 4 hospitals spanning the state. We do 60,000 cases a year, and G has a very big task of trying to make 120 anesthesiologists happy. So in this committee, we realized that we can really optimize our workflow. We can make the processes better, but we also realize that G has a lot of data and information that as an anesthesiologist, I don't have access to. I live my day in the clinical environment. It's very heavy clinical load, but through partnering with G, I'm able to get information that would take me months if I put in a front door ticket in Epic. And so we really are leaning into that partnership and collaboration to try to optimize our environment and make things better.
Thank you, Dr. Loba. So the partnership is very important for us. In pharmacy, for many years, we've been a very data-driven department. And see from this slide, we have access to almost every piece of data that comes into the system, from automated dispensing cabinets to the EHR, to the parking system, to transport, anything that comes to it, we get it, put it into the EDW, and we've been able to run dashboards off of it. These dashboards have helped us move forward in pharmacy. And so one of the things I heard yesterday was a conversation related to how are we going to use technology in the future. So in order for us to move forward in pharmacy, we took a lot of time studying the airline industry, like everybody mentioned before. One of the things that we learned out of the airline industry that was important was, how do you take this data and do it for the good? So airline industry, high reliability, high safety, and reduction of cost, right? So Airbus, a leading airplane manufacturer, decided they were going to take a look at what they could do to improve something. So what they did was they looked at all the options, pulled the data, and they figured out tires were an option to look at. So you think tires. Well, tire on an airplane costs about $15,000. You get 40 cycles with it. That means 40 takeoffs and landings, but they were only averaging 20, 25. When they started doing the study, they realized what happened is that each pilot has variability. So each pilot would step on the brake when landing and wear the tread down differently. So they said, hey, if we can get standardization, we can get these tires to last longer. So they built in AI that actually calculates, presses the brake, and lands it exactly where it needs to be. Why is that important at this meeting? I honestly think that that's the type of information that we can take from anesthesiologist workflow that's documented in multiple systems to try to figure out an auto braking system. How do we standardize IV syringes? How do we make sure what individual thing would make it easier for the provider to focus on what's important, right? Drawing up accurate syringes, right? Using technology to give pre-filled syringes. We can do that, but we need to know which ones to attack first, because you can't put everything as pre-filled syringes. So we started about going to dashboards. First thing we looked at is discrepancies. And these discrepancies helped us try to say, how do we level set with Dr. Loba? And so we pulled information in, we looked at it back and forth, and it helped reduce the number of discrepancies. If you have a discrepancy, you have to go back and have to answer for it. So these discrepancies, if we have a dashboard that provides you this information, and we're working on actually putting it on your phone. So you as an anesthesiologist can walk in and look and see if you have a discrepancy before and at the end of your case and solve it. So you're not being chased by pharmacy quality person or pharmacy data person over the auditing of narcotics. So that's one thing we're working on. We're looking at different types of anesthesia dashboards. We're looking at where we have population geotagging. We're looking at usage in different ORs. We're looking at total waste. We're looking at doses that were scanned but not administered. Things that we thought were impossible, for at least from the anesthesia perspective, when we talked to Dr. Loba, are becoming possibility. But what it takes is the partnership. That partnership between the subject matter expert, the data provider, and the provider of the medications. And I think we have a long way to go, but I think data is going to help us drive our decisions in the future. You know, everybody's heard "in God we trust" and everybody else must bring the data. That's the way we should be looking at anesthesia.
So the other thing that G has done for our group is technology. So anesthesia, I think it can be challenging to ask for technology implementation in the OR, and a lot of times you're told, well, that costs too much. I lean on G because G has money that I don't have. And so at TCH, we've been able to use things because he can see opportunity in utilizing that technology that helps on the pharmacy end, and he can have a selling point from that advantage. So at Texas Children's, we do use automated dispensing cabinets that I think provide a great opportunity to have access to the meds that we need. We tailor them for those cases that are done in that room or that environment. Right now, we are trialing the wave scanner at Texas Children's, which is an interesting addition because, as many have said, anesthesiologists are very resistant to change. They live in their own environment. And what I do every day, I don't want to be disrupted by something that is time limiting. However, sometimes you have to eat broccoli and asparagus, even if you don't like them. And so what I have shared with my group is I can't go to a leadership meeting again and say, well, we'll work on re-educating that provider based on that error. It's a horse that is beaten to death over and over and over again. So we really feel like you have to make the room smarter. I can't get any smarter. I truly can't. And so if the room is smarter, it can allow you the opportunity to provide great care that has a safety net. Because as many of you have said and highlighted, at Texas Children's, 70% of our attendings are by themselves in the room. There's no safety check. So how do you build in a safety check? Scanning that med, having audible readouts of that meds, alerting you to allergies can do that. The other thing which some people have, but I think is something that we need to strongly encourage, is not only pre-filled syringes, but those can be expensive. It's making syringes that tailor to your environment. So at Texas Children's, my ask, which G has promised by the end of the year, is robotically made meds. Using meds that are wasteful, like in a pediatric environment, dexmedetomidine comes in a big vial. I may use 3 cc's out of that entire vial and waste it. That's hard on my, green, crunchy Birkenstock wearing heart sometimes. And so I think that by having a robot and tailoring those, it provides a safety layer because the resident doesn't grab the whole vial and think, oh, I'll just give the whole thing, or the attendings can make the mistakes also, but really leaning on partnerships with pharmacy to bring that technology in to make the environment that you work in safer.
So as Dr. Lobos says, partnership. Our partnership looks at our current systems, electronic health records, opioid risk assessments, prescription monitoring, clinical decision support, all of this that ties into patient safety. The future is going to be smart packaging, mobile apps, drug diversion prevention, staff education, continuous evaluation, but it all starts with data, and data is going to be key. So we're looking forward to the evolution of where we go with anesthesia. I'm really excited that we can solve some problems, and sometimes it's not just the solution. Sometimes it's just understanding, do we have a problem? And using data to look at repetitious patterns that help us understand where we're going. Thank you.